next abstract is Does Length of Extended Resection Beyond Transition Zone Change Clinical Outcome for Hirschsprung Pull-Through, to be presented by Dr. Sarah Ulrich.
Thank you for the opportunity to present today. So, as most of this audience will know, Hirschsprung disease is caused by incomplete caudal migration of neural crest cells in utero, which results in an aganglionic segment of distal bowel. Between the ganglionated colon and the aganglionic distal segment, there's an abnormal transition zone with a reduced number of ganglion cells and abnormal hypertrophic nerves. When the ganglia migrate, they don't move all together in a straight line. It's more like paint dripping out of a can. This results in a transition zone that's asymmetric and is variable in length. When performing a pull-through for Hirschsprung disease, it's imperative to resect the entire transition zone. Otherwise, patients can suffer from persistent obstructive symptoms, recurrent enterocolitis, and may even require a redo pull-through. During the pull-through operation, the anastomosis is confirmed to contain only normal ganglionated colon with intraoperative biopsies. There are hints in the literature that advocate for the resection of a 5-centimeter margin of additional normal ganglionated colon proximal to the biopsy site to avoid the morbidity of a transition zone pull-through, but there's no strong evidence to support this practice. However, obtaining an extended margin of ganglionated colon isn't without its own morbidity. It can require the sacrifice of segmental blood supply and necessitate additional bowel resection beyond the desired margin, and leaving the patient with less colon can potentially contribute to difficulty with bowel control in the future. So we wanted to know if the length of the extended resection beyond the transition zone changes clinical outcomes for Hirschsprung disease pull-through. We performed a retrospective chart review of all patients with Hirschsprung disease who underwent pull-through at our institution from January 2008 to December 2022. We assessed postoperative outcomes as well as functional outcomes for children over 3 years old with the Pediatric Fecal Incontinence Severity Score. When reviewing the pathology specimens, we defined 3 areas of the specimen: the distal aganglionic segment, where ganglion cells were absent and hypertrophic nerves were present, the transition zone, and the extended proximal margin, which is the length of resected colon that's normally ganglionated. And for our analysis, we categorized the extended proximal margin as either greater than 5 centimeters or less than and equal to 5 centimeters. 87 patients met criteria for inclusion in our study. Median age at pull-through was 17 days, and just over half the patients had an extended proximal margin less than 5 centimeters. There was a statistically significant difference in the median age at diagnosis between the groups, but there was no difference in clinical or demographic characteristics, including the age at operation. There was no statistically significant difference in rates of postoperative enterocolitis based on the extended proximal margin length. We did observe a trend towards a decreased need for fecal diversion in patients who had a longer extended proximal margin, though this did not reach statistical significance. We also observed a trend towards decreased rates of redo pull-through in patients with longer extended proximal margins, though this also did not reach statistical significance. When examining the patients that had a redo pull-through further, of which we only had 6 in our cohort, we noted that 4 of the 6 did not have a circumferential examination of the anastomotic donut intraoperatively. We did not observe that there was any difference in the need for Botox or laxatives in patients based on extended proximal margin length, but we did observe a trend towards increased rates of enema usage with longer extended proximal margins, though this did not reach statistical significance. 61 children were greater than 3 years old at the time of our analysis, and pediatric fecal incontinence severity scores were available for about half of these patients. Median follow-up for these children were 126 weeks post-op. Children with a shorter extended proximal resection margin had improvements in daytime continence, and they were less likely to have involuntary daytime bowel movements. So to summarize, the extended proximal margin length did not have a statistically significant impact on postoperative complication rates, though there was a trend towards less need for diversion and lower rates of redo pull-through in patients with a longer extended proximal margin. It's possible that this represents a type 2 error from a limited sample size. However, shorter proximal margins were associated with a statistically significant improvement in some measures of fecal incontinence. In conclusion, I think the jury is still out on this question. In light of our findings, we advocate for an extended resection margin beyond the normal biopsy when it's possible. However, if a circumferential ganglionated ring at the proximal margin is confirmed intraoperatively, and getting a 5 centimeter margin would necessitate additional sacrifice of segmental blood supply, then we would caution against that just to get that 5 centimeter margin. Thank you. I'm happy to take any questions.
This abstract is open for discussion.
Program chair should have her own mic, by the way. It's already been requested. So I want to hear from the Hirschsprung SIG people if you think this would be a good study. Is this even something we could randomize? Do you think the PCPLC could do something like this? Because I feel like this dogma needs to be challenged. Any SIG people? Where's Jason? Come on. Get up there. I know it's probably your paper.
This is my paper. I won't comment on my paper, but as our Hirschsprung SIG group is working on a Botox study that we'll talk about, but as far as this paper is concerned, I think really you need to try to get that 5 centimeter margin. This came into conversation with our pathologists when we weren't getting 5 centimeter margins. You saw about half of our specimens were less than 5 centimeter extended margins, and our pathologists were raising concern. And so we looked at our functional outcomes in those patients, and it seemed that we were having equal functional outcomes in these patients. But the real key, and you alluded to it towards the end of your talk, is getting a circumferential confirmation that you have ganglion cells and no hypertrophic nerves when you're doing your pull-through. And I think that's really the take-home message. And we didn't have that either. If you look at a timeline, that became much more prevalent after 2018, and we sort of made it a mandatory part of our practice. But before that, it was sort of haphazard. And so I think those are the take-home messages from this paper. Thanks.
Mike Chen from Birmingham, Alabama. The question I have is when you do a biopsy, you get the ganglion cells. And then when you go up 5 centimeters above that, you still may be in transition zone as you go above that. So it's really impossible during the operation to really know that you're 5 centimeters above your transition zone.
That's true. I mean, you look at the papers on the pathology of Hirschsprung's disease, a large percentage of transition zones, and there are some large studies out there, are less than 5 centimeters in length. But there are some papers that show there are examples of greater than 10 or 15 centimeters of transition zones. So you never certainly that you're going well beyond. It's just a 2 standard deviation that you're going to likely get beyond that transition zone is my understanding of the literature.
Mm-hmm.
There's a question on this side.
I just have a little problem with some of the conclusions. You showed us a bunch of non-significant data, and then you have some functional outcomes, which can, but there's so many things that go into functional outcomes, you know, in terms of behavioral, sphincter, you know, social things, that just saying, hey, you should go 5 centimeters. I think what Dr. Fischer said is true, and it's been our practice for at least a decade to get circumferential biopsies and make sure that we're proximal to that and not distal, and not have those things to avoid the transition zone. And also checking, just like Dr. Chen said, you know, there's a paper many years ago from Ashley Hill and Dr. Jack Langer from that showed that transition zones went from about 2 to 2.5 centimeters. So I'm a little concerned saying, hey, go 5 centimeters, and then you end up with a stricture because of ischemia.
Right, I think that's a really great point, and you know, I agree with you. I just think that, and we agree, that if you see a circumferential, like, ganglionated ring at your anastomosis and you would have to resect way more colon to get that 5 centimeter margin, we would say don't do it. I just think that looking at like this graph, I would have a hard time saying, you know, we're not going to try to get an extended margin and avoid the need for redo pull-through.
We'll take one final question.
We have our first virtual question. It is, to what do you attribute the symptoms of the shorter margin patients? And unfortunately, I don't know where it's coming from.
So I think that the symptoms of the shorter margin patients, they're left with more colon because you're taking less margin, so they have less fecal incontinence, kind of based on our understanding of our bowel management program.
Thank you.
Thanks.